Alright, so I am going to show you today about a life-saving skill that you will have the opportunity to if you stay into the paramedic program. It's about endotracheal intubation. So what this is taking a plastic tube and we're going to place this in the trachea of a human person, this being a child that we're going to use today. The reason you'd want to do this is because we're trying to isolate the trachea itself. So if someone's unconscious or they're not breathing adequate enough, they're not going to have a gag reflex. And so the problem is that they're not going to be able to swallow. If they were to vomit and aspirate, then the vomit is going to go into their lungs. It is very caustic. It is very acidic. And so we're going to try to place this tube down their throat so that so they don't do that, because we obviously don't want that to happen. This is going to help us to be able to ventilate the patient at the rate that we need to ventilate them. We can make sure that the oxygen and the air is getting in all at one time. Because if we use a bag valve mask, which is just a bag that you squeeze, then it's going to actually get air into the stomach. So we're going to talk about why we do that. We're going to talk about how to go about doing the bag valve or the intubation today, and then we're going to talk about actually how to do it. We're actually going to show you how to do it, let you see what you're looking for and everything else. So again, I talked about the reasons why we do it. So the EMS World 2015 actually gave a report that said that 77% of all intubations are missed by pre-hospital providers. So 77% is not good, especially if that's going to be your loved one that you're wanting to be taken care of. You don't want 3/4 of all intubations to be successful. They say that it takes about 20 to 25 successful intubations to be able to predict that you're going to have above a 90% success rate. So that's why in schools, that's why at work, we want to be able to do this multiple times. We want to be able to do this consistently to know what we're looking for. You're going to have some of those patients that are going to be good patients that you're just going to be able to intubate with no problem. You're also going to have those patients that are not good whatsoever. They're going to have bad airways. They're going to have blood inside their mouth. Large people, you're just not going to be able to intubate them as well. So the more practice you can get beforehand, the better off you're going to be able to do it once you succeed. The people that set the North Carolina Office of EMS, they're the ones that are going to set the guidelines for who you're going to intubate. So we can go on the North Carolina Office of EMS, we can pull off our protocols that'll tell exactly why we need to intubate somebody, at what time we need to intubate. They say that we can only do 3 intubations at a time for the most experienced person on scene. So we will be able to do that. Once we met that limit of 3 people, then we would have to go to another, maybe like a failed airway device, which we'll talk about another day. So the University of Minnesota in 2012 actually did a study. They use these things that are called super glottic airways. So it's just a device that you just stick in the mouth. It blows a balloon up inside the mouth, and they were doing CPR. The study showed that when you use this type of device, that it actually pushed against the carotid arteries, and it actually decreased the amount of blood flow that's going back to the brain. So they had 8 pigs that were intubated with a normal intubation technique. They had 8 pigs that were using a thing called a king airway, which is just in the top of the mouth with a balloon. And it showed that in all eight pigs that were intubated lived, and all 8 pigs that had the supraglottic airway actually died. And that actually contributed to the decrease of blood flow going back to the brain. So that's why I think that the intubation is the best way to secure someone's airway. So let me talk to you about the different things that we have here. First, this is the intubation tube. This is an endotracheal tube. You can tell at the top here it hooks up to a bag valve mask. Here is a little bulb that when you blow it up, and I'll show you in a minute, actually has a bulb that blows up down here. It has numbers on the sides. This comes in multiple different sizes that we can use. You would determine the size of the tube depending on the size of the patient. A lot of times just their pinky You can use mathematical formulas that we can discuss, but you would have different sizes for different patients. And this is placed through the vocal cords, which I'll show you on the little image right here. We could place this into the patient that way. This is called a Stylet. This Stylet goes inside of the ET tube, and it is pretty much used to get the shape. So this holds shape. So you would put this in there and make the shape that you want. Usually the shape that you want is some kind of J formation, like a little light J. If you make it too much, then it's not gonna go in there properly. So we hold it at about a small J like that. You can also use this thing called a bougie, okay? This would actually be placed into the patient's trachea, and then you could take this intubation tube right here. You could actually take this intubation tube, stick it on here, and then you could push it in that way. So I'll show you both techniques. There's two different devices that we can use. First, this is called a Laryngoscope Handle. This is actually what you're going to hold to put the blade on. There's two different blades that you're going to use. One is a straight blade and one is a curved blade. Okay, this looks like curved like an apple, and so this is called a Macintosh blade. And this is straight like an L, and we call this a Miller blade. Okay, that's just some ways you can learn. This right here actually goes in the vallecula, which is the space between the tongue and the epiglottis. Okay, this goes in the vallecula and pulls up. This goes outside the epiglottis and actually pulls up this way. So this you would actually trap the epiglottis and pick it up. This one you go in the vallecula and lift up. This is another device, and this is what we're going to show you a little bit today. This is called the Glidescope, and this is a video laryngoscope. Okay, there we go. So this is a video laryngoscope. You can see it has a light on the end of it. Has a screen right there. You can lay it on the patient or beside the patient, and that'll give you a better indication. You can actually see a whole lot better than a lot of patients. A small child like this is not really going to be a big problem, so we're not, we can use it or don't have to use it. Another device we're going to use is the bag valve mask. So this is what we're actually going to put air inside their lungs with. This is a syringe that we're going to attach to our balloon right here. And when we attach this to the balloon, we're going to put air inside of it, and it's going to blow the end of the balloon. This balloon right here is going to be used to hold the ET tube inside the trachea itself. So we'll pull that out. We will stick our Stylet in. We want to make sure the Stylet does not go past the hole in the end right here. And the hole in the end is called the Murphy's eye. We want to make sure that it doesn't go past there. I'm going to use the curved blade. Again, it's called the Macintosh. This is a left-hand device. Doesn't matter if you're left hand or right hand. You're just going to place this in your left hand. So this is what the technique would look like. You would go in to the person's mouth. You would take the tube and you would slide it through their vocal cords and pull back out. So if you want to, you can step over here and look at this. Everybody see where the vocal cords are at right there? See where the vocal cords are at and see where the tube goes through? And those vocal cords look like that pretty much on everybody. They're nice and white. It looks like a big V right there. So you would just take and place it. Yep, just like that. All right. So that's another way you can do. You can also, like I said, you can take this bougie. You can place the bougie in the patient's mouth. Place the bougie in. And once that's in, you can take and put the ET tube over the top of it and slide it down. And when you slide it down, it'll slide right into their trachea. And then you will blow your balloon up, and that would stay in place. All right. So that's the technique of endotracheal intubation. Again, this is going to be something you will use one day. It isn't going to isolate the trachea. It is going to be able to maintain that constant airway to where you'll have that open airway back and forth. This is pretty much when the patient gets to the hospital, they're going to be put on the ventilator and they're going to be maintained at that point. So thank you very much for sitting in my session, and have a good day. All right.